Hey everyone, welcome back to Mental Wealth Reads. You're probably noticing a little bit something new behind me. We're having a little bit of a party here in a few days with some friends for the movie Wicked. So my roommate has already decorated the house to have the appropriate colors. So hopefully it's not distracting to you. If not, let me know in the comments. They're probably not going to be here in the next video, so it's just going to be a one-time thing. But just to explain. But welcome back, as I said, welcome back to Mental Wealth Reads. We're going to continue with Trauma and Recovery by Judith Herman. And we're going to start chapter 8. We're going to have to break this down into about 2. I think it'll just be 2 video episodes for just chapter 8. I'm as excited as I typically am for these chapters. This one especially, we're going to start talking about establishing safety within the therapeutic setting, and how that helps and how that works. And so it's going to be a nice new little behind the scenes sort of thing for all of you guys in terms of how we do it, and why, and all the little nuancy things that are going on in the background, or that you may not notice, but you can feel it, but you may not notice it. So without further ado, let's get started. Chapter 8, Safety. Recovery unfolds in 3 stages. The central task of the first stage is the establishment of safety. The central task of the second stage is remembrance and mourning. The central task of the third stage is reconnection with ordinary life. Like any abstract concept, these stages of recovery are a convenient fiction, not to be taken too literally. They are an attempt to impose simplicity and order upon a process that is inherently turbulent and complex. But the same basic concept of recovery stages has emerged repeatedly from Genet's classic work on hysteria to recent descriptions of work with combat trauma, dissociative disorders, and multiple personality disorder. Not all observers divide their stages into 3. Some discern 5, others as many as 8 stages in the recovery process. Nevertheless, there is a rough congruence in these formulations. A similar progression of recovery can be found across the spectrum of the traumatic syndromes. No single course of recovery follows these stages through a straightforward linear sequence. Oscillating and dialectical in nature, the trauma syndromes defy any attempt to impose such simple-minded order. In fact, patients and therapists alike frequently become discouraged when issues that have supposedly been put to rest stubbornly reappear. One therapist describes the progression through the stages of recovery as a spiral, in which earlier issues are continually revisited on a higher level of integration. However, in the course of a successful recovery, it should be possible to recognize a gradual shift from unpredictable danger to reliable safety, from dissociated trauma to acknowledged memory, and from stigmatized isolation to restored social connection. The traumatic syndromes are complex disorders, requiring complex treatment. Because trauma affects every aspect of human functioning, from the biological to the social, treatment must be comprehensive. Because recovery occurs in stages, treatment must be appropriate at each stage. A form of therapy that may be useful for a patient at one stage may be of little use or even harmful to the same patient at another stage. Furthermore, even a well-timed therapy intervention may fail if the other necessary components of treatment appropriate to each stage are absent. At each stage of recovery, comprehensive treatment must address the characteristic biological, psychological, and social components of the disorder. There is no single efficacious magic bullet for the traumatic syndromes. Naming the problem. Traumatic syndromes cannot properly be treated if they are not diagnosed. The therapist's first task is to conduct a thorough and informed diagnostic evaluation with full awareness of the many disguises in which a traumatic disorder may appear. With patients who have suffered a recent acute trauma, the diagnosis is usually fairly straightforward. In these situations, clear, detailed information regarding post-traumatic reactions is often invaluable to the patient and her family or friends. If the patient is prepared for the symptoms of hyperarousal, intrusion, and numbing, she will be far less frightened when they occur. If she and those closest to her are prepared for the disruptions in relationship that follow upon traumatic experience, they will be far more able to tolerate them and take them in stride. Furthermore, if the patient is offered advice on adaptive coping strategies and warned against common mistakes, her sense of competence and efficacy will be immediately enhanced. Working with survivors of a recent acute trauma offers therapists an excellent opportunity for effective prevention education. With patients who have suffered prolonged, repeated trauma, the matter of diagnosis is not nearly so straightforward. Disguised presentations are common in complex post-traumatic stress disorder. Initially, the patient may complain only of physical symptoms, or of chronic insomnia, or anxiety, or of intractable depression, or of problematic relationships. Explicit questioning is often required to determine whether the patient is presently living in fear of someone's violence or has lived in fear at some time in the past. Traditionally, these questions have not been asked. They should be a routine part of every diagnostic evaluation. When the patient has been subjected to prolonged abuse in childhood, the task of diagnosis becomes even more complicated. The patient may not have full recall of the traumatic history and may initially deny such a history, even with careful direct questioning. More commonly, the patient remembers at least some part of her traumatic history but does not make any connection between the abuse in the past and her psychological problems in the present. Arriving at a clear diagnosis is most difficult of all in cases of severe dissociative disorder. The average delay between the patient's first encounter with the mental health system and an accurate diagnosis of multiple personality disorder in 6 years. Here, both parties to the therapeutic relationship may conspire to avoid the diagnosis. The therapist through ignorance or denial, the patient through shame or fear. Though a small minority of patients with multiple personality disorders seem to enjoy and flaunt the dramatic features of their condition, the majority seek to conceal their symptoms. Even after the clinician has arrived at a presumptive diagnosis of multiple personality disorder, it is not at all unusual for the patient to reject the diagnosis. If the therapist believes the patient is suffering from a traumatic syndrome, she should share this information fully with the patient. Knowledge is power. The traumatized person is often relieved simply to learn the true name of her condition. By ascertaining her diagnosis, she begins the process of mastery. No longer imprisoned in the wordlessness of the trauma, she discovers that there is a language for her experience. She discovers that she is not alone. Others have suffered in similar ways. She discovers further that she is not crazy. The traumatic syndromes are normal human responses to extreme circumstances. And she discovers, finally, that she is not doomed to suffer this condition indefinitely. She can expect to recover as others have recovered. The immense importance of sharing information in the immediate aftermath of the trauma is illustrated by the experience of a team of Norwegian psychologists who took part in a rescue effort after a disaster at sea. Survivors of a capsized offshore oil rig were briefly counseled by a mental health team after their rescue and given a one-page fact sheet on post-traumatic stress disorder. In addition to listing the most common symptoms, the fact sheet offered 2 practical recommendations. Survivors were advised first to talk with others about their experience in spite of a predictable temptation to withdraw, and second, to avoid using alcohol for control of their symptoms. 1 year after the disaster, the survivors were contacted for follow-up interviews. Many of the men still carried in their wallets the fact sheet that they had been given on the day of their rescue, now tattered from many readings and rereadings. With survivors of prolonged repeated trauma, it is particularly important to name the complex post-traumatic disorder and to explain the personality deformations that occur in captivity. While patients with simple post-traumatic stress disorder fear that they may be losing their minds, patients with the complex disorder often feel they have lost themselves. The question of what is wrong with them has often become hopelessly muddled and ridden with moral judgment. A conceptual framework that relates the patient's problems with identity and relationships to the trauma history provides a useful basis for formation of a therapeutic alliance. This framework both recognizes the harmful nature of the abuse and provides a reasonable explanation for the patient's persistent difficulties. Though many patients are relieved to learn that their suffering has a name, some patients resist the diagnosis of a post-traumatic disorder. They may feel stigmatized by any psychiatric diagnosis or wish to deny their condition out of a sense of pride. Some people feel that acknowledging psychological harm grants a moral victory to the perpetrator in a way that acknowledging physical harm does not. Admitting the need for help may also compound the survivor's sense of defeat. The therapist Inger Ager and Soren Jensen, who work with political refugees, described the case of Kay, a tortured survivor with severe post-traumatic symptoms, who adamantly insisted that he had no psychological problems. Kay did not understand why he was to talk to a therapist. His problems were medical. The reason why he did not sleep at night was due to the pain in his legs and feet. He was asked by the therapist about his political background, and Kay told him that he was a Marxist and that he had read about Freud and he did not believe in any of that stuff. How could his pain go away by talking to a therapist? This patient eventually agreed to tell his story to a therapist, not to help himself, but to further his political cause. Though in the process he obtained considerable symptomatic relief, he never acknowledged either his diagnosis or his need for treatment. Kay said that he wanted to give his testimony, but that he also wanted to know why the therapist was willing to help him do that. The therapist answered that she considered it an important part of her work to collect information about what was going on in the prisons in his country. She also explained that it was her experience that it helped people who had been tortured and had nightmares about the torture to tell others about what happened. Kay then took the attitude of, well, if I can use the therapist for my own purposes, then okay, but it does not have anything to do with therapy. Often it is necessary for the therapist to reframe accepting help as an act of courage. Acknowledging the reality of one's condition and taking steps to change it becomes signs of strength, not weakness, initiative, not passivity. Taking action to foster recovery, far from granting victory to the abuser, empowers the survivor. The therapist may need to state this view explicitly and in detail, in order to address the feelings of shame and defeat that prevent the survivor from accepting the diagnosis and seeking treatment. Trauma robs the victim of a sense of power and control. The guiding principle of recovery is to restore power and to control the survivor. The first task of recovery is to establish the survivor's safety. This task takes precedence over all others, for no other therapeutic work can possibly succeed if safety has not been adequately secured. No other therapeutic work should even be attempted until a reasonable degree of safety has been achieved. This initial stage may last days to weeks with acutely traumatized people, or months to years with survivors of chronic abuse. The work of the first stage of recovery becomes increasingly complicated in proportion to the severity, duration, and early onset of abuse. Survivors feel unsafe in their bodies. Their emotions and their thinking feel out of control. They also feel unsafe in relation to other people. The strategies of therapy must address the patient's safety concerns in all of these domains. The physioneurosis of post-traumatic stress disorder can be modified with physical strategies. These include the use of medication to reduce reactivity and hyperarousal, and the use of behavioral techniques, such as relaxation or hard exercise, to manage stress. The confusion of the disorder can be addressed with cognitive and behavioral strategies. These include the recognition and naming of symptoms, the use of daily logs to chart symptoms and adaptive responses, the definition of manageable homework tasks, and the development of concrete safety plans. The destruction of attachments that occurs with the disorder must be addressed by interpersonal strategies. These include the gradual development of a trusting relationship in psychotherapy. Finally, the social alienation of the disorder must be addressed through social strategies. These include mobilizing the survivor's natural support systems, such as her family, lovers, and friends, introducing her to voluntary self-help organizations, and often, as a last resort, calling upon the formal institutions of mental health, social welfare, and justice. Establishing safety begins by focusing on control of the body and gradually moves outward toward control of the environment. Issues of bodily integrity include attention to basic health needs, regulation of bodily functions such as sleep, eating, and exercise, management of post-traumatic symptoms, and control of self-destructive behaviors. Environmental issues include the establishment of a safe living situation, financial security, mobility, and a plan for self-protection that encompasses the full range of the patient's daily life. Because no one can establish a safe environment alone, the task of developing an adequate safety plan always includes a component of social support. In cases of a single recent trauma, control of the body begins with medical attention to any injuries the survivor may have suffered. The principle of respecting the patient's autonomy is of great importance from the outset, even in the routine medical examination and treatment of injuries. An emergency room physician describes the essentials of treating rape victims. The most important thing in medically examining someone who's been sexually assaulted is not to re-rape the victim. A cardinal rule of medicine is, above all, do no harm. Rape victims often experience an intense feeling of helplessness and loss of control. If you just look schematically at what a doctor does to the victim very shortly after the assault with a minimal degree of very passive consent. A stranger makes a very quick and intimate contact and inserts an instrument into the vagina with very little control or decision-making on the part of the victim. That is a symbolic setup of a psychological re-rape. So when I do an examination, I spend a lot of time preparing the victim. Every step along the way, I try to give back control to the victim. I might say, we would like to do this, and how we do it is your decision. And provide a large amount of information, much of which I'm sure is never processed, but it still comes across as concern on our part. I try to make the victim an active participant to the fullest extent possible. Once basic medical care has been provided, control of the body focuses on restoration of the biological rhythms of eating and sleep, and reduction of the hyperarousal and intrusive symptoms. If the survivor is highly symptomatic, medication should be considered. While research in the pharmacological treatment of post-traumatic stress disorder is still in its infancy, several classes of medication have shown sufficient promise to warrant clinical use. In studies with combat veterans, a number of antidepressants have been moderately effective, not only for relief of depression, but also for intrusive symptoms and hyperarousal. Newer categories of antidepressants that primarily affect the serotonin system of the brain and also show considerable promise. Some clinicians recommend medications that block the action of the sympathetic nervous system, such as propranolol, or medications that decrease emotional reactivity, such as lithium, in order to reduce arousal and irritability. Probably the most commonly prescribed medications for post-traumatic stress disorder, as well as for a host of other ills, are the minor tranquilizers, such as benzodiazepines. These are effective for short-term use in the immediate aftermath of a traumatic event, although they carry some risk of habituation and addiction. The informed consent of the patient may have as much to do with the outcome of the particular medication prescribed. If the patient is simply ordered to take medication to suppress symptoms, she is once again disempowered. If, on the contrary, she is offered medication as a tool to be used according to her best judgment, it can greatly enhance her sense of efficacy and control. Offering medication in this spirit also builds a cooperative therapeutic alliance. Establishing a safe environment. From control of the body, the focus of safety progresses to control of the environment. The acutely traumatized person needs a safe refuge. From control of the body, the focus on safety progresses to control of the environment. The acutely traumatized person needs a safe refuge. Finding and securing that refuge is the immediate task of crisis intervention. In the first days or weeks following an acute trauma, the survivor may want to seclude herself in her home, or she may not be able to go home at all. If the perpetrator of the trauma is a family member, home may be the most unsafe place she can choose. Crisis intervention may require a literal flight to shelter. Once the traumatized person has established a refuge, she can gradually progress toward a widening sphere of engagement in the world. It may take weeks to feel safe in resuming such ordinary activities as driving, shopping, visiting friends, or going to work. Each new environment must be scanned and assessed with regards to its potential for security or danger. The survivor's relationships with other people tend to oscillate between extremes as she attempts to establish a safe sense of safety. She may seek to surround herself with people at all times, or she may isolate herself completely. In general, she should be encouraged to turn to others for support, but considerable care must be taken to ensure that she chooses people whom she can trust. Family members, lovers, and close friends may be of immeasurable help. They may also interfere with recovery, or may themselves be dangerous. An initial evaluation of the traumatized person includes a careful review of the important relationships in her life, assessing each as a potential source of protection, emotional support, or practical help, and also as a potential source of danger. In cases of recent acute trauma, crisis intervention often includes meeting with supportive family members. The decision about whether to have such meetings, whom to invite, and what sort of information to share ultimately rests on the survivor. It should be clear that the purpose of the meetings is to foster the survivor's recovery, not to treat the family. A little bit of preventative education about post-traumatic disorders, however, may be helpful to all concerned. Family members not only gain a better understanding of how to support the survivor, but also learn how to cope with their own vicarious traumatization. Relatives or close friends who take on the task of participating in the survivor's safety system must expect to have their lives disrupted for a time. They may be called upon to provide round-the-clock support for the basic tasks of daily living. The rape survivor Nancy Ziegenmeyer relied on her husband, Steve, for a sense of safety in the aftermath of the assault. Just 6 weeks had passed since a man had forced his way into her car at a Des Moines parking lot and raped her. The man was in jail, but the image of his face was still in front of her each time she closed her eyes. She was jumpy all the time. She cringed when friends hugged or touched her. Only a few people know about her ordeal. Nights were the hardest. Sometimes she'd doze off, only to have Steve wake her from a nightmare that caused her to pound on him over and over. She was afraid to get up in the dark to use the bathroom, so she'd ask Steve to take her. He became her strength, her pillar. Underlying tensions in family relationships are frequently brought to light during this sort of crisis. While intervention must focus on helping the survivor and her family to deal with the immediate trauma, sometimes the crisis forces a family to deal with issues that have been previously denied or ignored. In the case of Dan, a 23-year-old gay man, the family equilibrium was altered in the aftermath of a traumatic event. Dan was severely beaten by a gang of men in a gay-bashing incident outside a bar. When he was hospitalized for his injuries, his parents flew to visit him at the bedside. Dan was terrified that they would discover his secret, which he had never disclosed. Initially, he told them that he had been beaten in a robbery attempt. His mother was sympathetic. His father was outraged and wanted to go to the police. Both parents plied Dan with questions about the assault. Dan felt helpless and trapped. He found it more and more difficult to maintain his fictitious story. His symptoms worsened, he became increasingly anxious and agitated, and finally he became uncooperative with his doctors. At this point, a mental health consultation was recommended. The consulting therapist, recognizing Dan's dilemma, reviewed his reasons for secrecy. Dan feared his father's homophobic prejudices and violent temper. He was convinced that his father would disown him if he came out. A more careful review of the situation revealed that Dan's mother almost certainly knew and tacitly accepted the fact that he was gay. Dan feared, however, that in a confrontation she would defer to her husband, as she always had. The therapist offered to mediate a meeting between mother and son. The meeting confirmed some of Dan's perceptions. His mother had long known that he was gay and welcomed his coming out to her. She acknowledged that Dan's father had difficulty accepting this reality. She also admitted to a habit of humoring and placating her husband rather than confronting him with unwelcome facts. However, she told Dan that he seriously underestimated her if he believed she would ever break off their relationship or allow her husband to do so. Furthermore, she believed Dan had underestimated his father. You might be prejudiced, but he wasn't in the same category as the criminals who had beaten Dan. She expressed hope that the assault would bring them closer as a family, and that when the time was right, Dan would consider coming out to his father. Following that meeting, Dan's parents stopped questioning him about the circumstances of the assault and focused on helping him with the practical problems of his recovery. Establishing a safe environment requires not only the mobilization of caring people, but also the development of a plan for future protection. In the aftermath of the trauma, the survivor must assess the degree of continued threat and decide what sort of precautions are necessary. She must also decide what action she wishes to take against her attacker. Since the best course of action is rarely obvious, decision-making in these matters may be particularly stressful for the survivor and those who care for her. She may feel confused and ambivalent herself, and may find her ambivalence reflected in the contradictory opinions of friends, lovers, or family. This is an area where the cardinal principle of empowering the survivor is frequently violated, as other people attempt to dictate the survivor's choices or take action without her consent. The case of Janet, a 15-year-old rape survivor, illustrates how a family's response aggravated the impact of the trauma. Janet was gang raped at an unsupervised party. The assailants were older boys at her high school. Following the rape, her family quarreled over whether to file criminal charges. Her parents adamantly opposed reporting the crime because they feared public exposure would damage the family's standing in their small community. They pressured her to forget about the incident and get back to normal as soon as possible. Janet's older sister, however, who was married and lived in another town, felt strongly that the rapist ought to be put away. She invited Janet to live with her, but only on the condition that she agree to press charges. Caught in the middle of this conflict, Janet steadily constricted her life. She stopped socializing with friends, skipped school frequently, and spent more and more time in bed complaining of stomach aches. At night, she frequently slept in her mother's bed. The family finally sought help for Janet after she took an overdose of aspirin in a suicide gesture. The therapist first met with Janet. She ascertained that Janet dreaded going to school, where her reputation had been ruined, and she had to face continued threats of ridicule from the rapists. She too longed to see the rapist punished, but she too was frightened and ashamed to tell her story to the police or testify at trial. The therapist then met with the family and had explained the importance of restoring choice to the victim. The family agreed to allow Janet to move in with her sister, who in turn agreed not to pressure Janet to report the crime. Janet's symptoms gradually improved once she was allowed to retreat to an environment that felt safe. Okay, we're gonna stop there. That's gonna be our halfway point for today. I didn't realize I was leaning super far back here, but oh well. Anyhow, so there's a lot that they talked about in this chapter in terms of the feeling of safety, right? And how important it is with regards to having a space for you to heal in the therapeutic setting, right? And we kind of talked about this last video a little bit in terms of, if you don't trust me, or if you don't relate to me in some way, or if you don't think that your experience is going to, with me is going to help, right? It likely will not, right? And that's a lot of what they're saying in this chapter so far, is that the idea of feeling safe isn't just, am I in a place where I can certainly believe that my those who have abused me or those who have assaulted me or those who have caused my trauma are no longer here, right? Like it's much more complex than simply that. And this is something worth knowing, whether you're a victim or a therapist or somebody who just knows, is in the life of is somebody that's significant to one of these people, right? And it's important because you as a victim, or you as a loved one, or you as a therapist, right? You're all gonna feel the same sort of thing, right? Or you're all gonna see the effects of this, right? And we've talked about this in past chapters, but putting this in the context of the therapeutic setting, right? It's just not. It's not possible to. Well, I guess not possible. It's not reasonable to expect somebody who's been through something as atrocious as this, right, or something as damaging as this, to immediately trust anybody, right? It's simply not. It's just not possible, or highly difficult. I'll put it that way. It's highly difficult for a victim to get to that point, right? And part of that is because, the people who caused that trauma, right, were initially people who probably had a basic amount of trust from the victim, right? And it's not to say that they were necessarily somebody that the person knew or specifically said, hey, yeah, I trust this person. But there was at least enough trust for the victim to have entered into that environment where that person was, and believed that they had a chance of coming out of that environment unharmed, right? And that turned out to not be true, right? And so this is a place where it's going to be emotionally tricky for you as a victim, you as a loved one, and even me as a therapist, right, to navigate this emotional field, right? Simply because, like I said, the trust in the average human is not where it used to be within the victim, right? And it makes a lot of sense that that's that way. And even if you are a loved one, right? Maybe you're a partner of numerous years, or you're a sibling or a parent or whatever. It may be hard for you to accept that this person now that has known you forever, and you personally have never hurt them, they now don't trust you in some way, right? And I want to speak to that a little bit more specifically here, or at least I want to validate that. The fact that it's not your fault, and it's also not personal, right? It's going to be easy to feel like it is personal, right? It's going to be easy, even as a therapist, right? It's going to be easier rather to sit there and think to yourself, oh, but they don't trust me because I'm not competent, or I'm not a good fit for them, or they have already sized me up and down and decided I am not a good therapist, right? And that's simply not the case. What is at play here is just the fact that humans in general, right? Anybody else in this person's life is going to have that same sort of skepticism and that same sort of lack of trust, right? And like I said, it's not personal. There may be some aspects of it that the victim does feel are personal, in terms of like, hey, like you as somebody in my life, speaking to a family member or loved one or whatever, you may have been involved somehow in this situation, and maybe not directly, but you could have done something to change the course of this, this event for me. Or simply just thinking, you as my loved one should know how to help me through this, right? And that's a normal thought. That's a reasonable thought. It's not true. Well, I'll say this. It's not necessarily true in every case. Most of the time, you're going to find that, I think we kind of mentioned this in a couple videos ago, right? Just that idea of being the inadequate inadequate loved one, or the inadequate savior, right? Those feelings of hatred or disgust or whatever the emotion is, right? They're going to be directed towards the person who caused the trauma, but it's also very likely that they might get redirected towards you or me as a therapist, because now that distrust, is going to be sort of projected onto everyone, right? And again, this is not, I don't say this judgingly, I don't say this to speak ill of people going through this. This is just how this works, right? This is how the idea of trauma, or how the effects of trauma tend to work within the average person, right? That all being said, right, the point of this chapter is safety, right? I, as a therapist, need to establish safety on a number of levels. And like I said, me just being a good person who doesn't intend to hurt them is not enough, right? It can be sometimes. It just really kind of depends on the level of trauma. But it's not something you can reasonably expect to be enough every single time, with every single case. And that is simply because, like I said, every instance of trauma is actually unique. You might be able to put, your trauma in the same category as, the other 10 people in the room with you right now. Like all of you were in combat, right? And experienced combat trauma. But because each of you is unique, your individual traumas are going to be unique to each other, in their own ways. So basically what we have to do in the therapeutic setting is we have to be sure that you feel safe with me on a basic level, right? Like you feel safe, like this is an okay place to talk about your feelings. But also you feel safe on like an emotional level, right? You feel safe, kind of like the story that they were saying, the analogy sort of that they gave about, doing an exam on a rape victim, right? That examination may be a good thing, right? It may be geared towards you being able to do a rape kit or whatever and find out who did this, so you can put them behind bars and have closure there, right? It's more than likely not geared towards something negative. However, there are those little nuancey things, right? The fact that this person still is having to bear themselves literally to you as the doctor, right? And proceeding with that situation without care can re-traumatize, right? Because, like I said, even though it's a completely different sort of situation to you, right? Like, as the provider, you're not doing anything harmful to this person. There's still a vulnerability that is being asked of that victim, and that's the same vulnerability that was abused by the assailant, right? And we can relate this to trauma in all other ways too. It comes down to that level of gentility, right? The level of gentility, but also the intentionality of letting the person in the session with you help you lead them, right? The idea that they have as much control over their treatment as possible. I think it's something that I end up saying regularly to a lot of my clients with trauma, is that, like, here's what I want to do, right? Here's the pathway we're going to take. At some point, we are going to have to talk about your trauma. We have to name it, like the chapter says. You have to put a name to it in order to start healing from it. But right now, I am primarily interested in whatever pace seems safe to you and whatever action seems safe to you right now, right? Because not only does it help them for the environment to be safe, but it helps them to know that your intention is for the environment to be safe, right? Like I said, there's a lot of nuancy things. There's lots of layers here. And if you're doing your job as a therapist, right, these are the things you're going to care about. These are the things that are going to be important to you to establish every single time, right? And I don't know if the book necessarily says it in these words, but another thing to be mindful of is that you're never done doing that, right? Especially with clients with trauma, right? You're never done establishing a safe environment, right? Because you might find yourself in a place where it seems like, hey, like this client's really moving and shaking, like they're coming to session ready to talk, they've got stuff to talk about, they're just moving through it, and they're doing so good, and there's a lot of healing, there's a lot of coping, good positive coping happening in a lot of areas, and it seems like they really trust me now, and they might, it might be true that they have finally got to that place where they trust you, but you're not ever off the hook. You're not necessarily in a place where you can just now suddenly not be intentional or suddenly not care about how safe they feel, right? Especially if you're at a point where they trust you now to be talking about their trauma and really digging into those details, right? That's where you need to be extra intentional. And like I said, all for the reason of safety, right? Safety is the one thing that gets lost. And there's more than one thing that gets lost, obviously, but this is one of the big things. And safety, we can talk about, I'll probably talk about this in another video series, or maybe even in one of the courses that we're building right now, is Maslow's hierarchy of needs, right? If you've never seen it, you can Google it. It's basically this pyramid that's basically each little like part of the pyramid is something that each human needs, right? Like it's the hierarchy of needs in terms of emotional safety or emotional stability, right? And the number one, like the very bottom one, is safety, right? And the way that it goes is that typically the way that it goes is that if one of these is violated or harmed, the ones above it will also typically end up being affected too. It doesn't always happen that way, that every single one above is affected, but we typically that's how it goes. So that being said, safety being harmed in this sense, you're not just trying to rebuild safety because that's one isolated area of their life that's been ruined or harmed, but also because all the other needs that they have, all the other emotional needs that they have are going to be based off of that. And their ability to cope and their ability to build back their life is going to depend on how well you can help them regain that safety. I'm going to let you guys go there. I could talk forever about this, as you guys know. But do let me know what you think in the comments, as always. This is not an easy topic to dive through, and I do want to say, I appreciate all of you as viewers, whether you are someone trying to learn for a loved one, or someone trying to learn for yourself, or you're another therapist and you're just trying to get, some other insight basically on this situation. Either way, I want to really commend you for digging into this topic, right? It's difficult. It's heavy. It's difficult. It's pointy in some areas and prickly in others and sticky in some. It's honestly a field of landmines. Really what we need in this world, ideally for trauma, people to stop traumatizing each other. That would be wish number one, right? But in the meantime, in the imperfect world that we live in, the second best thing we can do is to learn. To learn about these things so we can master them. Master what we do with them, and master how we experience them, and also master helping others with it too. Because the more informed you are about this sort of thing, the better it is for people in your life that you know, or yourselves, in terms of recovery, right? The more you know, the more you can change the way you experience the world. with that, I'll let you guys go. Obviously, stay tuned for the next video. I hope to get it in next week, although next week is Thanksgiving, so I can't promise anything. I'll do my best. Yeah, keep commenting, keep engaging. I really appreciate you all. And again, if, like I always say, if there's anything that you want me to cover or anything that you want me to explain in more detail, do let me know. You can comment on the video, or you can visit me at the website, mentalwealthtoday.org, and send me an email, send me a comment of some sort, and just let me know what you guys would like to learn, because I'd love to teach. All right, you guys take care, and I'll see you in the next video. Bye.